Hi all, here I am, your English friend, with another video to explain part A and part B of sample 3 OET reading passage, which has been published on OET official website. So let's get started. Question number 1 in part A. Age-related considerations for initial treatment of burn injuries. Now this information can be found in text B, where they're talking about fluid resuscitation. And here you may see they are dealing with two groups of people, children and adults. In the last line of the first paragraph, you may see for physiological reasons, the threshold is closer to 10% in elderly, more than 60 years. They're talking about years there. And here you can find the group adults and children. So answer for question number 1 is B. Now question number 2. The risks involved in certain treatments. So treatment can be found in text C, where they are dealing with management for burns. Here in the third point, you may see they're talking about cooling. And here you can find cool the wound, not the patient, to taking care not to cause hypothermia. So that's the risk involved in that particular treatment. So answer for question number 2 is C. Now question number 3. When to start thinking about specialist treatment options. This information can be found in text D, which deals with adult analgesic guidelines. A table can be found there. In the third column on the right side, you may find severe pain, and in the last box under that heading, you may see if pain cannot be controlled with oral medications, consider admission to burns unit. So that's the specialist treatment options. So answer for question number 3 is D. Now question number 4. Treatment informed by patient self-assessment. So that's again in text D itself. Here you may see the table patient score elicited from patient. So the patients will be asked to score their pain level on a scale 1 to 10, on the basis of which analgesia would be recommended. So answer for question number 4, it's again D. Now question number 5. How to categorize the severity of a burn. Now that's in text A. Here in the very first line, you may see burn injuries are classified according to how much tissue damage is present. As you go further, you may see the first, second degree, then the third degree. So this classification is done on the basis of how much tissue damage is present. So now we know the information 5. Question number 5 is in text A. Now question number 6. Classification of burn injuries depends on the amount of dash cost. This information can also be found in text A itself in the very first line. Burn injuries are classified according to how much tissue damage is present. How much tissue damage is present. So classification of burn injuries depends on the amount of tissue damage. Now question number 7. Patients recovering from third-degree burns are likely to experience a great deal of shrinkage and dash of their skin. This also can be found in text A, because here you will find about the third-degree burn. Here you may see healing associated with considerable contraction and scarring. So contraction cannot be written because here they have given the information that great deal of shrinkage occurs. So we cannot write contraction, it would be a repetition. So our answer is scarring. Now question number 8. When evaluating mixed depth burns, you should take into account how the burn looks and whether there is dash in the affected area. This information is also in text A. Here under the subheading mixed depth burns. Burns are frequently of mixed depth. The clinician should estimate the average depth by the appearance and the presence of sensation. Appearance has been mentioned here, how the burn looks. So that's what appearance is called. Whether there is dash in the affected area. So what we need to write here as the answer for question number 8 is sensation. Now question number 9. You should cool burn injuries by taking off any dash or jewelry that the patient is wearing. So this is under management, which is in text C. Here you may see cooling, remove jewelry or hot clothing. That's a very simple question. Hot clothing. Now question number 10. When cooling the wound, make sure that you don't put the patient at risk of dash. Again, from the same area, here you may see, cool the wound, not the patient, taking care not to cause hypothermia. So, you don't put the patient at risk of hypothermia by cooling the patient. Now question number 11. The patient may require a dash booster depending on when they were last immunized. So here, answer for question number 11, again in the same text. In point number 5, you may see check immunization status and update tetanus if necessary. So a tetanus booster, answer is tetanus. Now question number 12. You should consider leaving dash undisturbed as these may help prevent infection. Again from the very same text, text C, here in the 7th point, debridement of blisters. There are some differences of opinion regarding breaking of blisters. Some suggest leaving intact because the blister acts as a barrier to infection, and others debride all blisters. So here, what should be left undisturbed? It's the blisters, according to some. Now question number 13. You should apply ointments containing dash to all deeper burns. Same text. Point number 8. Application of antibiotics in the form of ointment should always be used to prevent infection in any non-superficial burns. So answer for question number 13. Ointment that contains antibiotics. Now question number 14. In the case of mixed depth burns, what factor determines the local treatment to give? Answer for this question can be found in text A, again under the subheading mixed depth burns in the second para. Resuscitation should be based on the total of second and third degree burns, and local treatment should be based on the burn thickness at any specific site. So answer for question number 14, it's thickness. Now question number 15. What is the maximum number of tries recommended for attaching a drip at the scene of a burns accident? Now that can be found in text B here in the first paragraph. If the burn area is over 15% of the TBSA in adults or 10% in children, intravenous fluids should be started as soon as possible on scene, although transfer should not be delayed by more than 2 cannulation attempts. So that is the answer for the question. So the number of tries, it's 2, or you may write that in words if you want, but I would recommend you people to write the number. Question number 16. How much resuscitation fluid should a child receive per kilo over 20 kilogram? So it's again about fluid resuscitation. So same text, text B. Under the subheading children, we may find resuscitation fluid as above plus maintenance. Give 100 ml per kilogram for the first 10 kg body weight plus 50 ml per kilogram for the next 10 kg body weight plus 20 ml per kilogram for each extra kilogram. So up to 10 kg, that's going to be 100 plus 50 ml for the next 10 kg. That means still 20 kg. That's going to be these details. Now, when it comes to more than or over 20 kg, that's going to be 20 ml per kilogram for each extra kg. So here the question is, how much resuscitation fluid should a child receive per kilo over 20 kilograms? So answer for question number 16 is 20 ml. Question number 17. Before attaching a fluid resuscitation drip to a 9-year-old burns patient, what percentage of the body needs to be affected? So the patient is 9-year-old, so it's a child. So let's go through the same text. Here in the first part, we may see if the burn area is over 15% of the TBSA in adults or 10% in children, intravenous fluid should be started as soon as possible on scene. So answer for question number 17, as question is about a child, it's 10%. Now question number 18. What additional analgesic is recommended in the first instance for a patient with moderate level of pain? Now this can be found in text D. In the table, in the middle portion, in this middle column, you may find moderate pain. And the first analgesic that they are talking about is tramadol. So answer for question number 18 is tramadol. Question number 19. What route should be used to administer ibuprofen to children? Same text. Here you may find pediatric analgesia guidelines, and here the medicine, the drug can be found ibuprofen, and the route is oral. So it should be given orally. So question number 19, answer is orally. Now the last question. After how long should a patient's pain relief regime be re-evaluated? So from the same text D, it is quite clear that review must be done in 72 hours, or again in the third column also you may find the same information, review in 72 hours. So answer for question number 20, it's 72 hours. Question number 1 in part B. Doctors are advised to break patient confidentiality if. Here the answer is A, and it says failure to do so would put other people in danger. When we go through the paragraph in the first portion, you may see why confidentiality is so important for patients. And in the second para, you may see, however, faced with the situation in which a patient's refusal to consent to disclosure leaves others exposed to a risk so serious that it outweighs the patient's and the public interest in maintaining confidentiality, or if it is not practical or safe to seek the patient's consent, information should be disclosed promptly to an appropriate person or authority. So it means if a patient's refusal to consent to disclosure results in putting other people in danger or risk, or if it is not practical or safe to seek the patient's consent, then the doctors can break patient confidentiality. So that's why answer here is A. So it is right. Now let's discuss option B. Doctors are advised to break patient confidentiality if they inform the patient of their intention in advance. No, doctors cannot simply break this confidentiality by just informing the patient in advance, unless there is a situation that could endanger other people, or if it is not safe or practical to seek the patient's consent that we have read here in the middle portion for the previous question. So that option is not right. Now question number C. Doctors are advised to break patient confidentiality if a patient refuses to disclose information relevant to their care. Again, this is not right, because they may break the patient confidentiality if the patient is refusing, if there is a situation that could be potentially dangerous to other people. If that's not the case, then doctors are not advised and they're not permitted to break the patient confidentiality. Question number 2. According to the guidance notes, all staff involved in transferring patients from critical to general care must. Here the answer is B, which says ensure that patient's personal care plan is also transferred. This information can be found in this first portion. The critical care area transferring team and the receiving ward team should take shared responsibility for the care of patient being transferred. They should jointly ensure that there is continuity of care through a formal structure handover from critical care area staff to ward staff, including both medical and nursing staff, supported by a written plan. The receiving ward, with support from clinical care if required, can deliver the agreed plan. So these are the 2 points which support the idea which we can find in option B, that all staff involved in transferring patients should ensure that patient's personal care plan is also transferred. Now, when we deal with option A and option C, those 2 options are so easy for everybody to eliminate, because those 2 options are not mentioned anywhere in this area to be considered. So we don't have to discuss them much. Those 2 options are not given. Now question number 3. The memo says failure to screen a patient for malnutrition may result in? Here the answer is C, and it says care providers being unaware of an issue. This information can be found in the very first portion of the paragraph itself, where it says memo reminds staff of the importance of nutrition screening to identify problems which may go unrecognized and therefore remain untreated during the patient's hospital stay. So if there is a failure to screen a patient for malnutrition, then the care providers will definitely remain unaware of the issue and the patient might not be getting the treatment during the hospital stay. So that's what we can find here, and that's why option C is the answer. Now option A says a change in overall health, which we cannot really find anywhere given in this paragraph. And another option, a prolonged stay at the care facility, is also something which is not mentioned anywhere in this paragraph. So both option A and B are not given. So the answer is C. Question number 4. This policy document states that nurses, here the answer is B, which says can order medicines from the pharmacy in some cases. As we start from the beginning portion of the paragraph, we may see if stock levels of a medicine are low, the nurse should first liaise directly with their ward-based team to arrange urgent stock replenishment. So it is a ward-based team responsible to arrange the stock. But if the ward-based team is unavailable, the nurse should complete a request form online and email it to pharmacy stores, which means nurses can order medicines from pharmacy in some cases, and that is a case when the ward-based team is unavailable. Now let's consider option A and C. Option A says nurses must sign a paper form if they want a new stock. They must. No, we cannot say they must sign a paper form if they want a new stock, because in the last part of the first paragraph we may see paper-based ordering systems are available, but they are not reliable if ward stock is urgently needed. So we cannot really say, or we cannot really find any information in this paragraph that it is a must for nurses to sign a paper form if they want a new stock immediately or if it is urgent. So option A is wrong. Option C. The policy document states that nurses should speak to the pharmacist if a drug is needed urgently. There is no such information anywhere in this paragraph, so that's not given. Now question number 5. The extract from the guideline states that, here the answer is C, which says the ICU is fully responsible for a patient in their care. As we go through the paragraph, in the last part we may find we encourage collaborative patient-centered care. However, the ICU is defined as a closed unit. This means that when patients are admitted into the ICU, they are under the care of the ICU team. It is expected that members of the primary referring team will liaise daily with the ICU team to discuss the patient's management. However, it is up to the ICU team to make final decisions. This means the patients who are admitted to the ICU, or in other words, who are in their care, are completely the responsibility of ICU team. That's why option C is the answer for this question. Now let's deal with option A. It says ICU staff can be seconded to other ward. It means ICU staff can be transferred to other ward. Here the term seconded means can be transferred. There is no such information that ICU staff can be transferred to other wards anywhere in this extract. So that's clearly a not given. Now option B, it says only a consultant can refer a patient to the ICU. Here you may see that unplanned admissions to the ICU need a referral at consultant level. In exceptional circumstances, referrals will be discussed with the ward registrar looking after the patient if delay in referral to ICU would lead to the rapid deterioration of a patient. So from the first line, it is clear unplanned admissions to the ICU need a referral at consultant level, but there is no information that suggests that only a consultant can refer a patient to the ICU. So that's the reason why option B is wrong. Now question number 6. When dealing with the patients following a safety incident, staff must avoid. Here the answer is B, which says speculating on the possible causes of the incident. As we go through the paragraph, from the first part we may see information about a patient safety incident must be given to patient and or their carers in a truthful and open manner by an appropriately nominated person. As we go further, we may see it is also essential that any information given is based solely on the facts known at the time, which means whatever explanation has to be given to the patient and or their carers should be based on facts, and no speculations or any theory without evidence must be explained. Now let's consider option A and C. Option A says staff must avoid saying anything until the facts have been established. But here, the point that we have already read for the right option B, we know that they may give an information which is based on facts which are known at that time. They don't have to be established. So option A cannot be right. Now option C, staff must avoid contradicting what has been said by other staff. There is no such information given anywhere here, so that's clearly a not given. If you liked this video, please let me know about it through the comments, and don't forget to like, share and subscribe. You may click the bell icon to get prompt updates. Thank you for watching.